The statements and opinions expressed in this episode are those of Dr. Sigman and his guests, and do not necessarily reflect the views of Veradigm.
It's time to do healthcare smarter. This is Smart Medicine, hosted by Dr. Scott Sigman and powered by Veradigm. In medicine, what we name a condition matters. In the best of cases, it can tell you where to look and what's happening in the body. Most people don't think to question it, which is fine if it's pointing you in the right direction. About 10 to 13% of reproductive aged women have the condition we've called polycystic ovary syndrome, or PCOS. And for 90 years, that name was quietly leading physicians in the wrong direction. That was until a group of very smart people, today's guest among them, decided that it needed to change. And what they realized was that the place to start was with the name itself. In fact, they were so serious about getting it right that they even brought in marketers to help them rebrand the disease. Today, we're talking about what is now called PMOS, polyendocrine metabolic ovarian syndrome. My guest is Dr. Melanie Cree, a pediatric endocrinologist and researcher working at the front lines of this care. We'll get into where the old thinking went wrong and what modern research now allows a physician to do when a 13-year-old walks into the office with symptoms that no one can explain. Dr. Cree, welcome to Smart Medicine.
Thank you. Thank you for having me.
It's a pleasure to have you here. So before we dive into the science, let's let our audience and listeners get to know you a little bit better. You've spent much of your career caring for girls and young women who have often felt misunderstood or overlooked by the healthcare system. Was there a patient or a mentor or a moment early in your career that made you realize that this is the problem that I want to help solve?
I think my experience as a patient myself really made me want to provide better, more comprehensive care for women across the board. And so as I then went into my training as an MD and a PhD, was really looking to figure out where could I practice medicine in this effort where I felt like I could make the most difference. And so that is, over the years, how I got to this condition of PMOS, where I can combine my true vision for women's advocacy, improvements in women's health with my scientific training in metabolic conditions.
Fantastic. Let's dive into a patient's story, if you will. We'll use our imagination here. So Dr. Cree, I'd like you to picture a 15-year-old girl named Emily. She's been to several doctors. No one can explain why she's gaining weight or why her periods are irregular, why she's constantly fatigued, or why she has acne that's worsening. And she's starting to wonder, is it her fault? So how common is Emily's story, and what's really happening beneath the surface for this patient?
In my practice, that's almost all that I see. So I definitely have a skewed view. But within our teenagers within the United States, this is probably occurring, probably 7 to 8% of our teenage girls have this exact profile with excess weight gain, irregular menses, and then some additional symptoms of fatigue and excess acne. And they all can absolutely go together. And this generally is a medical condition that certainly is not the patient's fault for developing.
So today's conversation, we're going to talk about the former diagnosis of PCOS. And now this international panel of experts, including yourself, has made the new name, PMOS. So we'll spend time talking about why the change was made. But before we get there, I'd like to talk a little bit about the disease itself. So for our listeners who are hearing perhaps about PMOS for the first time, what is it?
So PMOS is a condition where women have too much testosterone. And women have testosterone, men have estrogen. It's not a male hormone or a female hormone, but the levels of testosterone are a little bit higher in women. And these lead to problems in having regular periods. And more testosterone, men grow beards, women can start growing beards on their face and facial hair and abdominal hair. They can start going bald like a man. And they can also have worse acne. So those are the symptoms that a patient normally experiences to bring them to care. They may be experiencing infertility because of these irregular periods. So that's what a patient might experience from the hormone perspective.
So what really surprised me as I was preparing for the interview was really just how common this condition is, right? But yet so many women are affected, but why is it that so many people, physicians alike, still underestimate its prevalence?
The majority is because of how women present and also related to the wrong name. So women with this condition typically come and see a doctor when they can't get pregnant. But what we know from some very recent data in the United States is only 16% of women with this condition actually experience infertility. So if the number one reason that patients are coming into care only affects 16% of patients, the others who have irregular periods but can eventually get pregnant or choose not to have children are not seeing a gynecologist for infertility and not getting diagnosed.
So I can imagine that many of these young girls are just a long delay in a diagnosis. By the time they get to an expert like yourself, this is all you do, they've been seen by their pediatrician, maybe they've seen an OB, maybe they haven't at this point, but yet, so that delay must really be very impactful to these young women and these girls as they're going through these very difficult times.
Absolutely. And we don't have any research on what's happening in adolescence. Now, we do know what's happening in adult women. The average time to diagnosis is 2 to 3 years, and the average number of physicians seen prior to diagnosis is 3 to 4. And these are in adult women who are advocating for themselves and their own health care.
Let's stop there because Dr. Cree just gave us a number worth focusing on. 2 to 3 years to a diagnosis? That's a long journey. According to the World Health Organization, up to 70% of women with this condition are undiagnosed, which means that 2 to 3 year delay, that's the best case. And each time we fail to diagnose, not only does it cost the patient, but it is also tremendously burdensome to the healthcare system at large. Researchers put the annual U.S. cost of PMOS at roughly $8 billion, and nearly half of that is treating the sequelae of strokes and the complications of type 2 diabetes. So here's some smart medicine. What if we spent more money on making the diagnosis? Think about how much we could save while improving the lives of the next generation of women. That's the wake-up call. The sooner we recognize what's happening, the sooner women get answers and the treatments they deserve.
The average time to diagnosis is 2 to 3 years, and the average number of physicians seen prior to diagnosis is 3 to 4. And these are in adult women who are advocating for themselves and their own health care. So you don't have then, sometimes girls can be very shy. They don't want to talk about their periods. They see one doctor, the doctor says it's fine. They don't want to open themselves up and expose them. So absolutely. And often when you talk to women who are diagnosed in their mid-20s, they'll say, I've had these symptoms since I was 13. And so really, from my perspective, part of the dissemination of this name and really having conversations like this is to make people aware of the condition so that they can ask their doctors and make their doctors aware to ask about it.
Yeah, so one of the missions for us here at Smart Medicine is really trying to help our audience distinguish good science from the misinformation that can spread so quickly online. We see that across so many different diagnoses. And unfortunately, PMOS or PCOS is another victim of that. What's the single biggest myth or misconception that you want to set straight today for our listeners about PMOS?
So to treat PMOS, we need to lower insulin. High insulin confuses the ovary and causes high testosterone. So there are so many people who feel that they are being dismissed They're just being told to lose weight. They're lazy. Is losing weight a side effect of treating insulin? Yes. But we are trying to lower the insulin. And so that is anything that decreases insulin. So exercising, make it better, eating less sugars, less insulin, sleeping better, less insulin, managing your stress, less insulin. And I think people need to understand that there is a biologic reason that we are talking about lifestyle changes. You may feel that your physician's being judgmental. I promise you, from the scientific perspective, we are not trying to be judgmental at all. We are trying to do everything that we can to help you lower your insulin, which will make everything else better.
I really love how you bring up the lifestyle side of things so often that we only think about medicines as the only way to go. We're going to talk about treatments. There are going to be some pharmaceutical treatments that we'll discuss because everybody knows right now the GLP-1s are a really hot topic. And I think it's just amazing to me how many different systems within the human body the GLP-1s can help. Sometimes we take a look back at the history and we realize that the medicine, we got the big picture not so right. We saw that, for example, with hormone replacement therapy. We've had a great episode on that, where the early interpretation of the evidence shaped clinical practice for years and really shifted our mindset. And I think listening to your story, I can't help but think that PMOS is sort of representing a very similar lesson. So how do you think that's going to really help us to evolve and think about PMOS no longer just as a reproductive disease, but as a hormonal physiologic disease as well?
Exactly. And again, this comes back to how women initially came to care. They came to care because they were growing a beard or they wanted to get pregnant. And so the original name was developed in the 1990 NIH consensus based around the data that we knew at that time. And then over the next 2 decades, we have really documented how much more cardiometabolic disease there is in women with this condition. So 8-fold higher rates of type 2 diabetes in adults, for example, who also struggle with weight. Increased risk of stroke and heart attack after menopause. So this is the entire lifespan, not just when you want to get pregnant in your 20s and your 30s. And so all of these data have come out so that in 2012, we started saying, hey, we've got to put something metabolic in here because at the end of the day, this is what's making more women sick. And so that started the conversation because we understood that it was so much more about reproduction. And again, coming back to this really great trial that's going on right now, 16% of women with infertility, 45% of women with cardiometabolic risk factors, and they didn't even include fatty liver disease or some of the abnormal cholesterol measures. So women are way more affected by the metabolic disease than the reproductive.
I think that Dr. Vonda Wright, who's a dear friend and one of our guests, likes to remind us that estrogen receptors are on basically every cell in the body. And if you starve your cells, whether it's in your brain or in your liver or in your ovaries, then they're not going to behave in the way that they were designed. So you were one of only 2 U.S. pediatric endocrinologists on the International Steering Committee that led to this effort. So walk us through this conversation now, because I know how important this is. Like, we sense your passion for really helping these young girls and women to really make a difference for them now, but also later in their lives. So walk us through how you were able to reach consensus and manage the name change at this time.
Yeah, so I was at that NIH conference in 2012 where we had 2 days of all this new metabolic research, and we said, oh gosh, we've got to change the name. Couldn't come to an agreement. And then the professionals all met in Italy in 2015 and said, okay, let's change it among us. And there was no consensus. And at this point, we had really started to have patient involvement as well. And so then we said, okay, fine. Well, the doctors can't agree. So let's see what the patients want. And let's do this through this formal voting system and open it up to the whole world. And so that's where we started. So the big question was, do we want to change the name? And the answer unanimously was yes. And these are surveys across the globe, thousands of people, patients, all different types of medical specialties. And then we said, okay, let's figure out how to do it and do it. And so then that's what we've been doing for the last 2 years, and making sure that we design questions for what do people like, send out the surveys, bring them back. All the representatives go through the results. We discuss the results in small groups, come back together. All the groups are led by patients. That's what's been amazing. And then in December, we couldn't come up with an acronym. And we said, well, you know what? Not a single one of us is in marketing. So we actually went and got a marketing firm because we realized that we didn't have the expertise within this group of medical experts and patient experts. So we got that, and then we were able to settle on a new name.
I think it's smart that you got the marketing team together. Actually, and PCOS to PMOS is an easy leap. It seems very similar as far as it comes across, just for me as an orthopedic surgeon, learning about it for the first time. What Dr. Cree has laid out so far is something every clinician needs to hear. We called this condition the wrong name for decades, and it made us miss the bigger story. What we're actually looking at is a metabolic disease, and that single realization is now reshaping how we treat it. That's exactly where Dr. Cree takes us next, because she's the one doing the research, including some early evidence on one of our favorite topics, GLP-1s, as they are now showing potential to treat PMOS. But first, this episode of Smart Medicine is powered by Veradigm. Veradigm connects payers, providers, and life sciences through data-driven insights that make healthcare smarter. Learn more at Veradigm.com. Let's talk a little bit now about your latest research and the GLP-1 connection, because I think that's going to be super important. So you started with the Apple study, right, which was to define the metabolic abnormalities occurring in young girls with this condition. And then you went to the Teal study, right, am I getting that correct?
We've got more in there.
Okay, well, walk us through it. Let's hear it.
So the AIRS study was using the gold standard research methods, difficult to do, where in the body has metabolic disease. And so these are high-dose insulin infusions called clamps, stable isotope tracers. And we said, okay, these girls have problems in their liver, their fat tissue, and their muscle tissue. And what was most surprising was that nearly 50% of these teenagers had excess fat in the liver. They also had carotid plaque at the age of 15. So then we said, well, how do you develop fat in the liver? When you eat. So then Apple was documenting these abnormalities in girls after our standard sugary drink test. And in that one, we said, well, what is the acute effect of a GLP-1? So we did 2 doses of exenatide and looked at exenatide in that trial, which started back in 2015, is when we first started looking at GLPs in this patient population. And then we did a couple other method trials. So we've got Plum was a methods trial. Orange is an amino acid trial to treat fatty liver disease, and which actually worked. And then we came to Teal, which Teal is the official color for PMOS. And Teal.
I love the colors, by the way. It's a great way to be able to think about it. Whoever came up with that was genius. I love it.
It sounds a little silly when you put them all in a row, but yes.
But you can remember it that way compared to all the other linguistics that we go with all these crazy studies that we do.
Exactly.
So good for you.
And so with Teal, we studied the effect of the GLP-1 that was on the market at the time. And so we used oral semaglutide that was only marketed for patients with type 2 diabetes. And all of these are approved by the FDA, and they take a decent amount of time. And so what we showed was that these GLP-1s induced a good amount of weight loss, even just over 4 months. We had a trend towards reproductive improvements and really really obvious metabolic improvements. So now we're doing the follow-up of that. Now we're using more modern medicines, and we're doing injectable semaglutide for 10 months. So now we have enough time to look at the reproductive cycle. And this one, the previous ones were teenagers. This trial is 12 to 35. And we are enrolling females with and without metformin. So metformin is the most common medication we use to lower insulin. So we want to know what is the combination of these two medications. So we have enrolled everybody for the semaglutide only arm. And the data were so remarkable, but when we designed the study, we didn't design the study to present any data in the middle of the study. But the data were so remarkable and there was nothing published, just everybody saying, I went on it and it helps. So we just published initial data actually a month ago. And we did only the women who lost at least 10% of their body weight. And we didn't use the primary outcomes for the trial. So we are actually measuring how many times these women ovulate before and after treatment. So what we've shown instead is how many times they have episodes of bleeding or menstruation. And we found that menstruation came back in 6 of the 8 women, and 2 of them went from absolutely no periods on their own to monthly periods. And that the testosterone, that high male hormone, dropped by 52% in these women. So really, really made a difference. But the thing that we also found is that one of these women lost that weight to the point that her body thought she was starving and absolutely shut down her reproductive axis. So if we're going to be doing this to help women get ready to have a baby, we need to really think about it in this patient population. Do we need to go slower in our rate of weight loss if we're doing this to improve fertility? I didn't go to the full dose in my trial. I only went to 1.7 milligrams. So it's super exciting, but then also says, hey, this is a different patient population and we may need to be doing the dosing differently.
Yeah, a lot to learn. I think it's interesting that you were so early on to the GLP-1s. 2015, 2016 was well early in the curve. And oral, just for our listeners too, the oral dosing doesn't absorb very well. It's a peptide. It gets broken down in the stomach. And so it's interesting when you went to the injectable that you are seeing more profound results. And again, for what I'm hearing here is we're going to learn how to titrate the dose here so that we're going to get the best possible outcome. And it's interesting, I'm going to do a segue here. The U.S. total fertility rate has fallen to about 1.6 births per woman, well below the replacement of 2.1. Most of the podcast hosts and the pundits out there would say it's all because of a social phenomenon, right? We're post-COVID, we're this, we're that, we're staring at our telephones. But I think the question is this PMOS really contributing? And then I think it'll be really fascinating to see as a more important, as you correct the endocrine dysfunction, will the ovulation and reproductive function early on allow these young women to be able to restore their normal metabolism, but then also be able to be more reproductive?
And that's exactly, we need big longitudinal trials. So in the last 10 years, my partners and I have set up a infrastructure, and I now lead a 19-center adolescent PCOS database, and we are trying to get funding right now for prospective trials or prospective registries to follow these girls who have taken GLP-1 and where are they going to be in 10 years. So we are trying to set that up right now.
Also, from what I'm hearing, Dr. Cree, is that we've really sort of treated PCOS from the outside in, right? Okay, you had acne, you had irregular periods, unwanted hair growth, fertility stuff, but really what we're doing now is getting to the heart of the problem and treating from the inside out. We're going to alter the metabolic imbalance, which is then going to hopefully make all of these systems work better. Is that reasonable?
Yes, absolutely. And we think that the high insulin is probably about 70% of women. There is a new medication for menopause that came out 2 years ago just for hot flashes. And what that does is it lowers our brain signal of luteinizing hormone. It lowers our brain signal to our ovary. And when you lower that LH, the hot flashes get better. There is also high LH in some women with PMOS, and they did early trials of a similar medication, and it worked great, but it was toxic. So is there, for about 20% of women who maybe don't respond to lowering their insulin, is there a future direction, again, by going right for where the problem is in the brain, not putting in a cover-up of birth control pills so that you bleed every month and feel normal?
Yeah, get to the source and try and figure out at the very source. So Dr. Cree, before we wrap it up, I want to leave our physician listeners with something practical they can use in their clinic tomorrow morning. So for our primary care doctors, our pediatricians, family physicians, OBGYNs that are listening today, what is the one thing you hope they'll start doing differently after hearing this conversation?
I hope you start screening for metabolic disease consistently and across the board because it is so prevalent. I would say number 2, don't blame the patient. This is a physiologic disease. They did not cause high insulin. So per the guidelines, technically it's a 2-hour oral glucose tolerance test. One of the 19 pediatric sites is doing that. The rest of us are checking hemoglobin A1C because of cost and expense. Technically, it's an OGTT. Number 2 is a fasting lipid panel. Number 3 is blood pressure, every appointment. And number 4 is not in the guidelines yet. We're working on it. And that is an ALT to check for metabolic associated steatotic liver disease.
That's really a great take-home message for our frontline doctors who are caring for these young girls. All right, so now for every parent who's watched their daughter struggle without answers, and for every Emily who's wondered, is something wrong with me? What do you want them to hear today?
I want them to hear that this is a condition that affects so many different parts of the body. And when you're thinking about care, you either want to work with different physicians who work together, or a family medicine or internal medicine doctor who thinks about multiple systems at the same time, because we need to treat reproductive and metabolic together. And if we treat both together, you're more likely to have success.
Wonderful. So medicine advances because someone is willing to challenge conventional thinking. So looking back over your career, you've certainly done that, and we thank you for that. And as you reflect on everything we've talked about today, what legacy do you hope that this work leaves for the next generation of physicians, and more importantly, for the next generation of young women who are living with PMOS?
So my hope is that our teenagers will be diagnosed as teenagers when they first present. My hope would be that we could get menstrual patterns as a vital sign for women. They can be abnormal from so many different things. And that if we can overall support patients in a healthier, less judgmental way and really improve the partnership between our patients and the people giving them accurate medical advice.
Dr. Cree, thank you for joining us today. Innovation in medicine requires more than great science. It requires the courage to challenge long-held assumptions and the persistence to change them. Here on Smart Medicine, we're passionate about sharing the stories of the innovators who have the courage to question the status quo, follow the evidence wherever it leads, and leave medicine better than they found it. Thank you for being one of those champions, and thank you for the work you're doing to improve the lives of millions of women around the world.
Thank you. And thank you, everybody, for listening.
I'm so glad we got to have this conversation today. When I reflect on why this name change is so important, we are essentially recognizing the broader implications of this syndrome. We're saying, look, treat this from the inside out, like every other metabolic condition. It's not about the acne or the hair growth. It's about the insulin and the hormonal imbalance. And to me, that common reframe is smart medicine. Thanks for listening. If you learned something today, and I hope you did, send this to someone who needs to hear it. When we spread the word, there's a patient on the other end who always benefits. This is the Fro signing off. See you next time.